Bismillahirrahmanirrahim. Seizure is a transient occurrence of signs and or symptoms due to abnormal, excessive or synchronous neuronal activity in the brain. The signs or symptoms of seizure could be either motor or non-motor, and so seizures could be motor seizures or non-motor seizures. The motor seizures are called convulsion. The seizure could be either provoked or unprovoked. Provoked seizure means it is caused by fever or acute cerebral insult, and we will discuss the causes of acute symptomatic seizures later on. The unprovoked seizures is called epilepsy when it is recurrent. So epilepsy is a recurrent unprovoked seizure. We mean by the recurrence that the child develop 2 or more attacks more than 24 hours apart. And we mean by unprovoked seizure that the seizure is not caused by a fever, it's not febrile seizure, and is not caused by acute brain insult. Seizures could be either focal or generalized. Focal seizure occur when epileptic discharge originates in only one side of the cerebral hemisphere, while generalized seizure is due to generalized epileptic discharge. The focal seizure could be either motor or non-motor, and also generalized seizure could be either motor or non-motor. Generalized motor seizure could be either clonic, atonic, tonic, myoclonic, or generalized tonic-clonic seizures, while the generalized non-motor seizure is the absence seizure. On the other hand, the focal motor seizures could be either focal clonic, atonic, tonic, or myoclonic, while the focal non-motor seizure could be either sensory, behavioral, autonomic, cognitive, or emotional. During focal seizure, the child could be conscious and aware of the surroundings. This type of focal seizure is called focal aware seizure. While some children with focal seizure may have impaired awareness, this type of seizure is called focal seizure with impaired awareness. Sometimes the focal seizure may become generalized, so the seizures with focal onset and secondary generalization is called focal to bilateral tonic-clonic seizures. Generalized motor seizures is either generalized tonic-clonic, clonic, tonic, myoclonic, or atonic, while the generalized non-motor seizure is the absence seizure. When the onset of seizure cannot be defined, is it focal or generalized, it is called seizure with unknown onset, and sometimes it is called unclassified. 2/3 of children with epilepsy have normal MRI brain, and no organic brain lesion can be detected in these children. It is called idiopathic or primary epilepsy. More than 90% of children with idiopathic epilepsy have positive family history of epilepsy, suggesting a genetic inheritance, and it's mostly autosomal dominant or non-Mendelian inheritance. On the other hand, 1/3 of children with epilepsy have organic brain lesion, and they detected in their MRI brain, and it's called symptomatic or secondary epilepsy. Symptomatic or secondary epilepsy could be due to congenital etiology, either congenital hydrocephalus, cerebral malformation, or vascular anomaly, or could be due to a previous CNS infection, either post-encephalitic or post-meningitic, or due to brain abscess, or could be a complication of cerebral neurocytosis. Congenital infection also, like congenital toxoplasmosis, congenital rubella syndrome and cytomegalovirus infection could be a cause for symptomatic epilepsy. Symptomatic or secondary epilepsy can also occur as a complication of a previous head trauma or prolonged hypoxia or prolonged hypoglycemia, and also can occur in children with brain tumor or degenerative brain disease. During generalized tonic-clonic seizure, the child will lose his consciousness with eyes rolling back. Tonic contraction of upper and lower extremities on both sides occur, alternating with clonic contraction. Tongue biting, loss of bladder control may occur during the attack of seizure. Following the attack of seizure, the child may fall asleep, may have headache or confusion for a certain period of time. Some children with focal to bilateral generalized tonic-clonic seizure may have aura, which denote the focal onset of seizure in some children. Seizure could be precipitated or triggered by some factors that decrease the threshold for occurrence of seizure. For example, lack of sleep, vigorous exercise, illness, fever, stress, bright light or flashing of light, some medication, for example cyphilin, sudden withdrawal of anti-epileptic drug, skipping of meals or specific food or excess caffeine. All these factors could be a precipitating factor for seizures in some children. 6-year-old girl has been referred for evaluation because her teacher noted that she frequently have staring spells. The child seems to come back to responsiveness very quickly without confusion. Her reading and math skills were average, but now they are slightly below grade level. Her mother also noted that there are times when the child stops talking, stares and blinks her eyes for several seconds. We asked the child to hyperventilate, and after 2 or 3 minutes of hyperventilation, an attack of staring occurred and the child lose her consciousness without falling. The attack only lasts for a few seconds. On examination, the child had normal general and neurological examination. A healthy 6-year-old girl presenting with staring spells and decline in academic performance. What is the diagnosis? Childhood absence epilepsy. What is the differential diagnosis? The differential diagnosis of difficulty in school and daydreaming include absence seizure and complex partial seizure, or non-epileptic conditions such as attention deficit hyperactivity disorder, learning disability, and so on. Diagnostic workup. If we suspect absence seizure, we should ask the child to hyperventilate for at least 2 or 3 minutes. Hyperventilation will provoke the absence seizure. EEG is required. A characteristic EEG pattern of spike and slow wave occurring at a rate of 3 per second is characteristic of childhood absence epilepsy. The management of children with childhood absence epilepsy is at least 2 years of long-term antiepileptic medication. Isoxamide, valproic acid, and lamotrigine are the drug of first choice in these children. Myoclonic seizures are short involuntary muscle contraction of a localized group of muscle. The upper limb are more commonly affected. The seizure occur more frequently in the morning after awakening, and loss of consciousness is momentary. 9-month-old infant presented by recurrent episodes. that have been started since 3 weeks. The episode usually occur upon awakening, but sometimes happen as he is going to sleep. In the episode, the infant suddenly flexes his knee towards his abdomen, and his arm bends at the elbow, and his hand may clench. Each episode lasts for few seconds, and they may occur repeatedly over many minutes. What is the type of seizure? It is infantile spasm. Taking the developmental history of the child, we found that he sits unsupported, bubbles, and recognizes his name when called. His obstetric and family history were unremarkable. EEG was requested, and it revealed hips arrhythmia. There is disorganized background with high amplitude spike and slow wave. Infantile spasm is a type of generalized seizure that occur in infants. The peak age is around 4 to 8 months of age. There are 3 types of infantile spasm. The flexor type, like we have seen in the video, it looks like a colic because the infant usually flexes his lower limb and upper limb towards his abdomen. The extensor type produces extension of the extremities. It looks like the Moro reflex. And the mixed type, where sometimes flexion or extension occur in the same infant. Infantile spasm disappears before the age of 4 years, and it could be followed by another type of seizure. 10 to 20% of infantile spasm are idiopathic and occur in developmentally normal children. However, 80 to 90% of infantile spasm are related to prenatal hypoxia, tuberous sclerosis, cerebral malformation, or inborn error of metabolism, and they are called symptomatic infantile spasm. There is characteristic EEG pattern of hips arrhythmia. The treatment of infantile spasm is mainly by corticosteroid or ACTH. Antiepileptic medication called vigabatrin is the first choice antiepileptic drug for treatment of infantile spasm in children with tuberous sclerosis. A tonic seizure or drop attack is characterized by sudden loss of muscle tone and fall to the ground. In infant, it may occur as sudden drop of the head. It may be associated with momentary loss of consciousness, but no tonic or clonic movement. Diagnosis of epilepsy is essentially clinical. It depends on detailed history from the parent and maybe also observation by the physician. EEG is helpful to detect the epileptic activity, and a characteristic EEG pattern may be detected in some epilepsy syndrome. However, EEG may be normal in 30% of epileptic children, and normal EEG does not exclude epilepsy. Prolonged video EEG monitoring may be helpful in some children. MRI brain is required in infant presenting with epilepsy and in adolescent, and also in any children with neurological abnormality or in focal epilepsy or drug-resistant epilepsy. Epilepsy should be differentiated from recurrent events that mimics epilepsy, mainly the breath-holding attacks, syncope, and pseudo-seizure or psychogenic convulsion. Treatment of epilepsy: healthy lifestyle and adequate sleep, avoiding the precipitating factors of seizures. Moderate exercise is desirable, but violent exercise may precipitate fits. Parents of epileptic children should be taught the seizure first aid in order to manage the attack of seizure if it occurs at home. Parents of epileptic children should know how to manage the seizure. The seizure first aid: they should not be panicked during the seizure. They should put their child in a semi-prone position with the head turned to one side and stay near the child, recording the time or the duration of seizure, placing something soft under his head to prevent the injury, and not to put anything in his mouth. If the seizure lasted more than 5 minutes, they should call ambulance immediately. When the child reaches the hospital, oxygen is given. Correctable causes of convulsion should be managed. Hypoglycemia and hypocalcemia should be detected early and treated. Intravenous diazepam is given slowly intravenously to control the seizure, and the dose can be repeated after 10 minutes for a single time if seizure continued. If there is no intravenous line, diazepam can be given rectally in a dose of 0.5 mg per kilogram. Long-term anti-epileptic drug is indicated if the child experiences 2 or more attacks of seizure more than 24 hours apart. Anti-epileptic drug is indicated after a single attack of seizure if the patient is neurologically abnormal or had focal brain lesion, for example brain tumor, or has epileptiform activity in EEG. The principle of giving the long-term anti-epileptic medication is to start low and go slow. Only a single anti-epileptic drug known to be effective for the type of seizure should be used in a small dose and increased gradually at interval of 2 weeks till the seizure is controlled or maximum dose is reached. If the maximum dose of the drug is reached and there is no control of seizure, a new anti-epileptic drug should be introduced and gradually increasing the dose till control of seizure, and then starting withdrawal of the first anti-epileptic drug. We should try to avoid double or triple anti-epileptic drug treatment as far as possible. The treatment should be continued for at least 2 seizure-free years, and then after a normal EEG, gradual discontinuation of anti-epileptic drug is done over a period of 3 to 6 months, and avoid sudden withdrawal of anti-epileptic drugs because it may cause status epilepticus. Phenobarbital, phenytoin, and carbamazepine can be used to control focal epilepsy and generalized tonic-clonic seizures. In addition, phenobarbital is the first-line treatment used in control of neonatal seizure. Phenobarbital and phenytoin are also available in intravenous formulation and can be used as a second-line anticonvulsant drug to control status epilepticus. Sodium valproate and clonazepam are broad-spectrum anti-epileptic medication. They can be used to control nearly all types of seizures. Ethoxamide is the first drug of choice used for treatment of typical childhood absence epilepsy. However, ethoxamide can exaggerate focal and generalized tonic-clonic seizures. Vigabatrin is the drug of first choice in treatment of infantile spasms in children with tuberous sclerosis. It can be also used to control focal seizures. Lamotrigine and levetiracetam are new anti-epileptic medication. They are broad spectrum and can be used nearly to control all types of seizures. Oxcarbazepine and topiramate are new anti-epileptic medication. Oxcarbazepine is mainly used to control focal seizures, whereas topiramate is a broad-spectrum anti-epileptic drug. Status epilepticus is a continuous seizure lasting more than 5 minutes or serial seizures between which there is no regain of conscious level. Status epilepticus is medical emergency. The definition of status epilepticus was changed from a convulsion lasting more than 30 minutes to 5 minutes only because recent studies has proved that prolonged seizure for more than 5 minutes is more difficult to control and brain insult will occur, and so management of seizure should start at 5 minutes in order to prevent the brain injury. Etiology of status epilepticus. Status epilepticus can occur in children with febrile seizures, and it is called febrile status epilepticus. And it occurs in children with epilepsy due to sudden stoppage of anti-epileptic medication or missed dose of anti-epileptic drug, or maybe due to exposure to a precipitating factor, and of course in uncontrolled epilepsy. Status can also occur in acute symptomatic seizures. Status epilepticus management. As status is a medical emergency, so emergency stabilization is needed using the ABCD approach. The airway patency by suction, semi-prone position, maybe need for airway, breathing should be adequate circulation, intravenous line is needed to give the intravenous anticonvulsant, exposure examination plus immediate random blood glucose measurement. Anticonvulsant drugs should be given to control the seizure. If seizure continued for 5 minutes, we should start by giving intravenous midazolam or intravenous diazepam or intravenous lorazepam. When there is no intravenous line is available, midazolam can be given intramuscular, diazepam can be given rectally, and lorazepam can be given by the buccal or intranasal route. If the seizure continued after the first dose of benzodiazepine, a second dose of benzodiazepine can be given, but no more than 2 doses of benzodiazepine is allowed. After that, if seizure continue, a loading dose of phenytoin is given in a dose of 20 mg per kilogram. Phenytoin should be given slowly intravenously. On the other hand, phenobarbital may be used instead of phenytoin, particularly in a neonatal seizure. If seizure continues, a second-line anticonvulsant drug should be tried, either sodium valproate or levetiracetam. If seizure continue, general anesthesia, admission to PQ and general anesthesia is required.